All right, we're recording. So I can see Jim Cameron, no smoke. Paul Frieda. Okay. So who I see right now are Jake Hannon, Peter Kafka, Bill Franklin, Frank Kelly, Jim Cameron, Mel Smoke, and Paul Frieda. Anyone else?
This is Sylvester Mann on the telephone.
Okay, Sylvester Mann, we got you.
Frank, you got me, Albert.
And Albert, good. I'm glad you joined, Albert, because Frank, I want you and Frank to compare notes. So
Okay, thank you.
I just mentioned your name to Frank.
He said they took my name in vain.
Yeah, but that wasn't to Frank. That wasn't to Albert. That was to somebody else who's not on the call right now. They may join because they were on the wrong call yesterday. All right. What time is it? Well,
About 3 after.
3 after. We'll give people a couple more minutes. Oh, Professor Bill, how are you? That's good. I guess he's sort of with us, but not quite.
Here, I need my second over there.
Oh.
That's my wife, you guys. Leave her alone.
That's okay. We're getting a lot of background noise, so you know you're bringing attention to yourself there.
Okay.
All right. So I see Jake Hannon, Peter Kafka, Bill Franklin, Frank Kelly, Jim Cameron, Mel Smoke, Paul Frieda, Sylvester Mann, Albert Biasio, and Bill Burhans. Anyone else?
Rich Catapano.
Rich Catapano. Welcome, Mr. Catapano.
Thank you.
Oh, we're going to have plenty to talk about tonight. Even without new guys, I see we're going to have plenty to talk about tonight. So let me just pull up my meeting notes because I know some people called in. Okay, so both Albert and Mel are on the line. That's good. So we can we'll kick off with I'm going to go through everybody, but we'll kick off with Albert, and then that actually segues into the Mel Smoke question. So we'll cover Albert and Mel up front. And then, Frank, it'll also involve you, but you had some other comments, so I got you down for a question. And let me go through everybody else now. Jake, how about you?
No, Rick.
No. Peter?
I'm okay. No questions.
Okay. Bill Franklin, how about yourself?
All right. Good. Can you hear me?
I can hear you. How are you?
Okay. Yeah, good. My tablet's acting weird, so.
Okay.
I plugged headphones in. The mic didn't work before, so.
Oh, okay.
Yeah, I did that question several weeks back about the bone density scan, so I got my results.
Okay, we'll come back to you for sure. Jim Cameron, how about you?
Nothing tonight, Rick. I have to leave early. I didn't realize I had a homeowners meeting tonight, so I can't stay the whole night, unfortunately.
Oh,
I'll be leaving early.
You can always check in later or tomorrow and listen to us on the recording for what you missed.
You know I will.
Okay. Okay. Mel Smoke, I've got you down for questions about the heterogeneity of prostate cancer. So we will definitely be talking about that, because I know what Albert and Frank want to talk about, and it will cover it, and then we'll expand it a little bit more for you. Paul Frieda, anything for you?
Nope, not for me tonight.
Okay, Sylvester, how about yourself? Sylvester, anything for you?
Not at this time. I'm doing
Okay.
pretty good.
Okay. Professor Bill, welcome. Anything for you that you'd like to talk about tonight?
I have no questions, but why don't I just give a very brief update of the news that I told you on the phone?
Oh, absolutely. Yeah. No, we'll come to you for it. We will check in with you for your news, because it's great. Rich Catapano, we've been talking about a couple of things, so I think we'll check in with you if that's okay.
Sure.
Okay. And Eric, anything for you? Yes, something for you. Okay, something for Eric. I can see Eric because he's got his video on. All right, so let's start off with Albert, who wrote me earlier on about his new chemotherapy regime. Albert, why don't you jump in here and tell the other guys what you told me, and let's talk about these new chemotherapy agents a little bit. Did you get the response I sent to you with a couple of references?
Yes, I did, Rick. I was at work. I didn't have. I glanced through them. They were really quite good.
Okay.
But I haven't had a chance to absorb it in my mind yet.
No problem. I just wanted to make sure that you got them. I may post them up on the. I may post them in the chat box as well. It might be helpful for other people. But please go ahead.
Okay. About a year, 2-3 months ago, I was on Xtandi. The Xtandi stopped working. My PSA was down to about 0.01, 0.02, roughly around there. Stopped working, and then it was the typical, it was the bookcase doubling every month. So we went to the first line chemos, and they didn't work. And then there was the first line, and I forget what the names were, Rick. You probably know them offhand. The typical ones that they do. The first one started with a C, and I was on there for 4 months, but that didn't do anything. And then the second line didn't do anything. Went to Xgeva.
Hold on one second, just so we can help the other guys. You probably, I think, as I recall, you started with cabazitaxel or Jevtaz,
Right, yes.
right?
Yeah.
Which is normally the second line, and that didn't work. So then you tried the first line, which was the Taxotere.
Exactly.
Docetaxel.
Okay. Yeah, and then that didn't work either. This is probably 6-7 months into the regime. Went to Xgeva with what's the one you take prednisone with?
Zytiga.
Zytiga, exactly. And that didn't work either. On all of these, it didn't even phase the cancer. So ultimately, in November time frame, my PSA had gotten up to over 1,600. Now, I was asymptomatic. Thank heavens for that. You know, maybe a little bit tired or something like that. Then the doctor decided to put me on carboplatin and what's this one here? Alimata. And they together.
Spell that second one for me.
Sure. It's ALIMTA.
Alimta.
Right.
I don't.
They aren't targeted chemos like the other ones were, but I was extremely castration resistant. I mean, the ADT and all those other things just don't work anymore. This one, though, so from 1600, within probably about 3 weeks, I was down to 800 or 700, roughly around there, and then a couple weeks later, down to 500. I'm not sure what it is now. We haven't done the PSA recently. Probably this week we will. The only issue with this is that it really wipes out your blood cells. It's everything. So I periodically, once every 3 weeks, maybe 10 days after the chemo, I have a blood transfusion, and that helps bring me back up. But the platelets are also compromised, and like I was supposed to have chemo last week, and my platelet count was low, so I'll have it this week, hoping that the platelet counts will increase. Those are about the only drawbacks with it.
So, a couple of things that I just want to mention. It's not uncommon that the chemotherapy drives your blood counts down, and in fact, it happens with both docetaxel and cabazitaxel. So in a way, it was good that you got through those and it didn't bother you. I mean, I used to know. I know of a guy who used to get blood almost every time he got a docetaxel, and that went on for a couple of years. So it's not unusual. Some people think there's a bit of a downside. Some people don't think there's much of a downside. But if it makes you feel good and allows you to take the chemo and you weather your chemos relatively well, then you know, it's not uncommon. The fact that you're responding to carboplatin is also not an uncommon, what should I say, an uncommon protocol. About 3 or 4 years ago, a paper was published by Paul Korn, who treated our friend Jay, who passed last year, and by Andrea Hartstark, who I know very well, and she's one of the treating doctors for Dr. Steve and for Ben Gulo. And I've actually put those up in the chat window for those of you who are on GoToMeeting. And what they found is that if you had small cell or neuroendocrine cancer, that you probably were likely to respond to carboplatin, to a platinum or to a platinum-based drug, to a platinum-based chemo, and in particular carboplatin. It's a shame that Steve isn't on, because he could tell you more about these platinum-based chemos than I know. Now, you were not diagnosed with small cell cancer. We know that because it would have shown up in the biopsies, and they would have looked at your slides and they would have said you got small cell cancer. So, you know, the question is, why is it that you're responding to carboplatin? And this gets into Mel Smoke's question about, well, what type of cancer, of prostate cancer, is suitable for what type of treatment. prostate cancer is incredibly diverse, way more diverse than we ever thought. I mean, some of you can remember we used to talk about, and we were amazed, there are 28 different types of prostate cancer. Well, you know, now if you ask somebody like Eric Small or Chuck Ryan or some of these researchers, they'll tell you, you know, there's well over 100 that they've seen, and they're identifying new types frequently. And the reason is because the cancer morphs, it changes over time. And as it changes, it's going to respond to different types of treatment. So as it becomes more like a small cell cancer, even though it isn't literally a small cell cancer, it starts to behave like a small cell cancer, or a neuroendocrine cancer, which, by the way, is very similar to small cell. I honestly don't know technically if there's a difference between small cell and neuroendocrine. I don't think you can use them interchangeably, but my understanding is that they're very, very similar. Professor Bill can probably tell us that in a moment. But as the cancer becomes more and more like a small cell cancer, so the treatments for that small cell cancer become effective. So what we're seeing in a person like yourself, Albert, who has been resistant to the common treatments from early on and got a little bit out of docetaxel and Jeptana, but not a heck of a lot, is that you have a more complicated cancer. And it's acting like a small cell cancer. I don't know Alimta. I just pulled it up again. Maybe Bill knows more about Alimta. It's also called Pemetrexed, I think, or Pemetrexed. But it's often combined. Carboplatin is often combined with the etoposide, which is the drug that Frank was just on, that didn't seem to do a heck of a lot for him. And it wouldn't, I don't know, Frank's going to tell us in a minute, but I wouldn't be surprised if Frank's now on a platinum-based chemotherapy. So let me ask Bill. Bill, first of all, can you tell us, is there a difference between small cell and neuroendocrine cancers?
I'm embarrassed to say I'm not certain. I think they are the same.
Mm-hmm.
Don't quote me on that, and I'm going to look that up as we're talking later on. But I think, so I'm not clear, Albert, about exactly what you said earlier. So you did respond to carboplatin, is that right?
Yes, actually, within I can. What I'll do is I'll get the whole history and send it to Rick. But I believe it was like within 2 to 3 weeks that it dropped. My PSA dropped by 50%, and 2 to 3 weeks later it dropped down to 500. So the doctor was. I mean, he was, you could see the smile from one end of Greenville to the other on his face. I mean, he was
Sure, yeah.
ecstatic with it.
So carboplatin is a kind of drug that damages DNA. And you know, one of what's become really clear is that prostate tumors, as they evolve, develop more and more mutations in proteins that are required for repair of DNA damage. So I think that the fact that you're responding to carboplatin probably means that you're, accumulating mutations in those pathways. And because your DNA repair systems are no longer capable of repairing the lesions, they're more effectively killing your tumor cells. Does that make sense?
Yeah, I guess. The only question is, since it does affect the DNA, is it affecting the DNA on my normal cells too? Or just, go ahead.
Yeah, it does, but not to the same extent, because the damage is actually converted into into the lethal lesions during the replication of DNA, and most normal cells are not replicating their DNA. So, the part of the basis for their selectivity of a drug like carboplatin for tumor cells is that tumor cells, unlike your normal cells, are continuing to replicate their DNA. And so that's when they, when they run into a lesion that's caused by carboplatin, they run into a lot of trouble. So the carboplatin does, it does damage DNA in normal cells, but not to the same extent as it does in tumor cells.
Okay.
And etoposide is another DNA damaging drug. And I think that, Rick, you said something about someone else on the call earlier getting a combination of carboplatin and etoposide, is that right?
Not on this call right now, but I've seen carboplatin and etoposide given pretty frequently. I think Dom got carboplatin and etoposide, and other people that I've known have gotten carboplatin and etoposide. It's usually a fairly late stage selection.
Right. So I think that the reasoning behind that is that they're both, potent DNA damaging agents, and so, but they damage DNA in different ways. And so, basically it provides you more coverage to selectively kill cancer cells. But as far as how to go forward, I'm not, what are the doctors suggesting for, that you do going forward from this point?
I know. I mean, I think that what you're doing for us is incredibly helpful. Is that you're explaining to us how these drugs work and why they're selected. I mean, I have a really basic question because I'm not much of a scientist or biologist. But you mentioned that regular cells, when they reproduce, they don't carry their DNA with them, but cancer cells do. Is that what I heard you say, Bill?
No, they don't. Most normal cells are not replicating their DNA because they're not dividing. And there are exceptions to that. Cells in the intestinal epithelium and in the hair follicles, for example, and all the places where you normally see side effects of drugs. So in those cases, the normal cells do divide because that's part of their, it's required for their proper function. But the vast majority of the normal cells in your body are not dividing, and they're not replicating their DNA. Tumor cells are dividing and are replicating their DNA, and a lot of these drugs work by, introducing modification to the DNA that makes it difficult for the DNA polymerases that replicate DNA to get past them. And so that leads to additional damage, and that's what ultimately kills tumor cells selectively while leaving most normal cells without killing most normal cells.
So how does if a cell doesn't split to recreate itself,
okay,
how does it reproduce?
What do you mean if it doesn't? What do you mean by split?
I mean, if it doesn't divide, if a cell doesn't divide, I mean, we have cells in our body. We're making new cells all the time.
Right, but at a very slow rate. So all cells do eventually divide,
okay.
but they're dividing at a very slow rate.
Okay.
Except for tissues like intestinal epithelium or hair follicles.
Okay. So What we're saying is that all cells divide, but those cells that divide very quickly, which would include cancer cells as well as nails and hair and other issues and other cells that are characteristic of the side effects of chemotherapy, divide much quicker. And because they divide much quicker, these drugs are a lot more effective and impactful, and that's why they work on stopping the growth of the cancer.
Exactly.
Okay.
But the interesting thing about prostate cancer, though, is that at least at early stages, compared to most other types of tumors that form in other organ sites, prostate cancer tumor cells initially divide very slowly. And so, you know, this has implications for treatment. You know, it makes it, you know, that it makes it much more, they're difficult for those cells to respond to the, you know, the types of treatment that normally are used for other types of cancer.
Right, which is probably one of the reasons why until recently chemotherapy was never introduced as a standard treatment on diagnosis of the disease, because...
Exactly. That is the reason why, yes.
Okay, well, geez, this is great because this really explains a lot. Let me open it up so that people can ask you some questions, and then we'll come back to pemetrexed and we'll come back to the discussion. This is a great discussion. Anybody have any questions they'd like to put to Professor Bill?
I'd just like to say thank you, Bill. I mean, this is worth the price of admission today. It's an amazing clarification. I never really understood why people's hair fell out with chemo, but this paints a pretty clear picture.
Oh, okay, great. I'm glad that I helped. Yeah.
Immensely. Anyone else want any clarification or any other questions? Okay.
No, that was really good, Bill, Professor Bill.
I'm sorry.
So, just one other thing, Professor Bill. With ADT, we end up building up a resistance to it. Now, is there the possibility, will we also see resistance to the carboplatin where it doesn't work anymore?
I don't think so, but I'm not absolutely certain about that. And I think the reason why I don't think that's the case is because it's a relatively short-term treatment, where androgen deprivation therapy is, you know, much more long-term. The resistance develops when, you know, some of the proteins that are involved in the pathways that are impacted by these drugs start accumulating mutations. And so, you know, a lot of these drugs are designed to fit into a particular shape of a molecule. But if that molecule, that protein undergoes a mutation that alters its shape, then the drug no longer, you know, can interact in the same way. But that requires a lot of time. And, you know, drugs that, like carboplatin, I think are usually given over a much shorter period of time, and there's not enough time for those mutations to accumulate.
Okay.
Excellent. Now, the other drug that they're giving you, pemetrexed, it's not a drug that I'm familiar with. I don't know that we've ever had anybody on the calls before that has been administered that drug. I have posted a link which explains the drug. It's a Cancer Research UK link that I chose, usually because their pages are very good and their explanations are very good. And you'll find a lot more about this drug, Alimta or pemetrexed. The one thing that is really interesting to me is that it says pemetrexed is a chemotherapy drug used to treat non-small cell lung cancer. So here we have a prostate cancer that's becoming more and more like a small cell disease, and that's why we're using carboplatin, and we know that from the research that carboplatin can be effective, but they combine that with a drug which is used to treat non-small cell cancer. So they also say that pemetrexed is used to treat mesothelioma. I think that's the cancer that you get from asbestos. In combination with cisplatin. Well, cisplatin is another platinum-based drug like carboplatin that I know has been used on. Some people do better on cisplatin than they do on carboplatin. There are a bunch of platinum-based drugs. Now, the platinum-based drugs have a whole slew of side effects that are not necessarily as common in the taxane-based drugs. And I think one of those is that they have a heavier impact on, and I don't know why, but they have a heavier impact on your blood counts. I would have to, I honestly can't remember off the top. I would have to look. I think they also have a tougher impact on your gut. If I'm...
Yeah, Rick? I can check on this. I have a doctor's appointment Thursday. But I believe what the pharmacist, when I had the first chemo, said was that I have to take a folic acid every morning now. But it does attack, or it utilizes the folic acid, which the blood cells also need. Mm-hmm. So that might be why it attacks. But I'll find out when I talk to him and let you know.
Yeah, well, actually, the folic acid is to do with, because I'm looking at it right here. Some of you can let me share my screen, and then okay. So can you see? I'm not sure which screen is being shared. I've got two screens. Can you see? Can you?
Oh, there it is. Yeah, I see it.
Okay. So if you see here how you have pemetrexed, right here, take folic acid tablets starting 5 days before, and vitamin B12. So the folic acid that you're taking has something, I'm not exactly sure what, but it has something to do with the pemetrexed rather than the carboplatin.
Okay, actually, Rick, actually I'm taking ALIMTA.
That's the same thing.
Oh, is it? Okay, I'm sorry. I apologize.
So
here at the top. Oh, okay.
So Rick, folic acid is a precursor to the building blocks of DNA.
Uh-huh.
So it ultimately, if you inhibit folic acid production, you inhibit DNA replication once again. And this is, most chemotherapeutic drugs attack DNA replication in one way or another. And I'm not familiar, unfortunately, with pemetrexed, but I'm guessing that it's similar to, or perhaps derived from methotrexate because of the similar sounding name. Mm-hmm. And that's another drug that inhibits pathways that involve folate metabolism. Mm-hmm. And it's a very, very old chemotherapeutic drug. Mm-hmm. And it can have a profound effect on blood cells in particular that are dividing very rapidly.
Now,
but why? How? What I don't know is when you would use it, what circumstances you would use it under. I mean, remember, I'm not a clinician, mm-hmm. and I haven't. I haven't come across this drug earlier. Once again, I'm going to do some research, and I can have some answers for you at the next time, in the next call.
Well, I seem to recall, and I think this comes from Dom, God rest his soul, that the hair loss is not as noticeable with the platinum-based drugs, although it may be with this when you include the Alimta. I also noticed here that they mentioned that bruising happens quite easily, and you may notice that too, Albert, that you just get a tiny little bang and then you bruise badly. I've known that happen to people.
Yeah, my wife's had to stop hitting me, so that's a plus.
Okay. Hey, listen, we should allow her back in the room now to defend herself. No?
But she's talking to her friends. It's Chinese New Year this Friday and Saturday, so they're making plans.
Okay. Okay, yeah, the year of the rooster, if I'm not mistaken.
Yeah, you're absolutely right.
I know. We need May and Dan on the call tonight. Maybe they'll join us later, and we can ask them what they're doing. Let me flip over to Frank Kelly. I know we've got three or four new people that have joined us, and we'll check in with you in just a second. But let me flip over to Frank Kelly and talk to him about the chemo that he's getting, and if this conversation is ringing any bells or helping him understand a little bit about what's going on with his treatment.
Yeah, I'm here.
Okay.
Hello?
We're listening to you, Frank.
Okay, well, they switched me back over to docetaxel. Because they'd already ordered it. And next time they're going to give me the other Taxel. And they were only going to give me 2 rounds of it and go to a immunization drug that's used for cancer or lung cancer and
right.
another kind of cancer. It's not approved. It's off-label use for prostate cancer.
Right. The drug they were going to give you is nivolumab or called olaparib.
Okay, I don't know what it is yet because we're still deciding on what I'm doing.
Right.
So anyway, that's the second time on docetaxel, and I only started a week ago Monday, and it feels as bad as the 5th or 6th session.
Right.
That happened the first time I did docetaxel. Right.
Well, like I said to you, I think in the last session, and we also mentioned in offline when we wrote that I don't know why this guy didn't give you Jevtana this time, the one that he's ordered, because it's known to have lesser side effects, and it's another taxane.
What's this one called?
The one that you're going to get this next time is called Jevtana or cabazitaxel.
Yeah, it'll be cabazitaxel.
Cabazitaxel, 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 and it's a gentler drug. Let me ask Albert. Albert, did you notice a difference between the Jevtana and the docetaxel and the Taxotere? We can't hear you. You're muted. You'll have to start over.
No, not really.
Okay.
I did lose hair with both of them, but nausea, no diarrhea, kind of a normal life, really. I exercised, my blood counts didn't drop that much. So to me, they were both about the same.
Okay. I wish, Frank, I'm hoping that when they give you the Jevtana, that you're going to feel less side effects from it. When are you due in about a week and a half?
Yeah, a little over a week and a half.
Yeah. And then the other question I had, which I wrote to Lisa, is I'm not really sure why they're using nivolumab, and I sent that question to our experts, to Larry Fong and to Tom Harding, and Tom Harding gave us a really good response, which I'm sure Lisa has, which talks about certain mutations that they look for for these drugs, and and I think this is true for Albert too. I mean, I think both of you should do your best to try and get a better genomic sampling. I know, Frank, you've tried, it didn't work well, and then they couldn't get into the first one, and then you shut down.
Both my oncologists have refused basically to do the test over again.
Well, if it were me, I would have a problem with that.
Yeah.
Because I mean, for them just to say, okay, we don't know what your genomic makeup is, but we're going to throw this drug at you is
crazy.
It's not professional.
Well, the thing that they both say is that it's interesting because you're just saying the opposite, was that there are very few mutations of prostate cancer cells, and basically they're all the same. And that's exactly the opposite of what you said, so I couldn't get in an argument with him about that, not being knowledgeable enough.
It's not true. There are many mutations, and this is one of the problems. I mean, I'll send you an article. I mean, 2 years ago, the Dream Team here in San Francisco came up with a whole new type of prostate cancer that they named, because it had such unique, that they found in many different prostate cancers about 70 gene mutations that were common to several different types of prostate cancer. And so they decided that this was going to be a new category of prostate cancer. And this is happening all the time. So, there's absolutely no research that suggests that nivolumab has effect on prostate cancer. Now, a similar drug, these are anti-PD-1 drugs. A similar drug called pembrolizumab or Keytruda, there is some research going on. And if they were giving you Keytruda, I would say, okay, I can understand why they're doing it. But just to pick a drug when they don't have the basis, and they're refusing to allow to try and get a better sample, is crazy. I mean, if it were me, and it's up to you to do it, but if it were me, I would absolutely insist. I would walk in there and say, let's do an MRI, let's find a bone lesion that can be biopsied, and let's go in and get a bone lesion and get it analyzed. And do it sooner rather than later, because at 110 pounds, you need strength. And don't piss around with this. I mean, again, this isn't medical. I'm not giving you medical advice. I'm just talking background. I'm not saying take this drug or take that drug. We don't have the information to know how to treat you, Frank. And we can get it. If we couldn't get it, it would bother me. Anybody, Bill?
No, I agree with you 500%, Rick. But so what kind of genomic testing did you already have, Frank?
Pardon?
What kind of, you said that you've already had some genomic testing?
Yeah, well, they tried to do a biopsy on the cancer in my back, and they missed it. I mean, you can see on the CAT scan, because it was CD guided, they got real close, but they didn't get anything of it. So we went, it was brand new, we went to the blood test, and because it was brand new, they screwed that up and didn't send the right paperwork in. So they did it again with a blood test, and that time we came back no actionable genes. And that took about 3 months to work through. And I don't know, I've been working on this for about another 3 months, and they just seem to think that it's a waste of time to do another biopsy.
Well, the problem with
the blood one.
The problem with the liquid biopsies, which is what I think you're referring to when you say blood test. They drew blood, and then they tested it for mutations, They isolated tumor cells from it and then looked for mutations from that in those tumor cells. And the problem with that approach is that it's possible to identify mutations in only about 60 different genes, where material from a biopsy, not a liquid biopsy, but one where they go in and retrieve material from a tumor. A place like Foundation One will be able to look for actionable mutations in 360 different genes. So the liquid biopsy that you had is much more limited in looking for actionable mutations. And it seemed, boy, if I were you, I'd go back to them and argue that, they missed the first time, but that's not a reason to try again if there's a, lesion that's large. If they think there's a lesion that's large enough and that's in a place that's not going to be dangerous to biopsy, then I would argue with them that you should have it done again.
Well, and I agree with you because it's free and Foundation One takes care of all the bills too. But
Yeah.
just banging my head against the wall on it as far as my wife even said, look at the, they're the experts and they say they can't get any more out of it.
Yeah.
Next time I see him, I'll push a little harder. This is my new guy. I've just seen him one time. Replaced my retired guy.
Well,
Are they academic oncologists?
Pardon?
Are they academic oncologists? Do they work at a cancer center?
Yeah, they work at a cancer center.
Yeah.
Yeah, but they're not. They're affiliated to University of Washington, but they're in a remote location in Idaho, Bill.
Oh, okay.
They are connected to University of Washington.
Okay. I know of someone who is in southern Idaho and goes to, there's a terrific cancer center in Salt Lake City. Is that out of the question for you to go to?
Oh, that's huge distance. Southern Idaho from northern Idaho is quite a long ways.
Yeah, okay.
And I don't travel well at all anymore.
Yeah.
Okay. I've got to drive. Now, I did have one thing to say about the bipolar treatment, which I thought was really weird, is we did the 3 sessions for 28-day cycles, 14 on the cancer drug and 14 on, well, the testosterone shot was supposed to be big. I don't know how long it lasted. He said 5 to 8 days. And a month and a half, 2 months after I quit it, my PSA dropped by a point. And I wasn't on anything. I don't know what that means, but while I was on it, every time it went up and almost doubled a month. It went up probably 2/3 a month. And then the last PSA test I did, it dropped probably 0.9. And I don't know if anybody can explain that at all.
So what are your PSAs now, Frank?
5.8.
5.8.
Yeah, it was up to 6.7.
Okay.
Until I did the last, and I wasn't doing anything then. I'd been off the etoposide and the testosterone shots.
The explanation, I don't want to say explanation. I can give you a hypothesis because I don't think we really know at this point. But one of the hypotheses is that these large doses of testosterone re-energize the androgen receptors and they bring them back to life. And so that when you stop taking the testosterone, you respond again to the lupron.
So you think the lupron's what's doing it?
So, it's the lupron that's, that it's feeding, it's stopping these cells from feeding. In the past, they had learned to live on very, very little testosterone. Now, all of a sudden, they get a whole bunch of testosterone. And so they get used to that, and then you take the testosterone away, and a bunch of the cells have like readjusted. And when you take it away, and you're not making any testosterone, they die off.
Okay, so you think a 2-month period of passing can still have that effect? Huh?
Yeah, because that it takes these cells time to adjust. I mean, that's one theory. But then there's another counter theory that says, well, one of the reasons why you get an impact when you actually get the testosterone is because these androgen receptors are absolutely flooded with testosterone, and they drown in the testosterone and they die. So, that would be the other side of it. So do they drown and die at the time that you get the testosterone? Maybe. Or does the testosterone re-energize these androgen receptors? And so later on, when the testosterone is taken away and they don't have as much testosterone, do they die off? That's another possibility. I mean, I don't think we really know. This is so new.
Because I was wondering whether all I was doing was feeding my cancer with the testosterone. And
well, that's always been the theory, but that's why they go from one to the other. Not with you because you were on the ATAPA side, but with the other drug. With the other test, they're giving you high doses, and then they're giving you Zytiga or enzalutamide, and then they're giving you them back to the high doses, and then the Zytiga and the enzalutamide. So there are different theories.
Yeah.
And the fact that your PSA, and of course you don't make much PSA anyway, so a point for you is like 500 points for Albert. Your disease, I mean, just because you don't make much PSA and you're going from 6.8 to 5.8, I mean, that's a 12% drop, 15%, 16% drop, which is comparable from Albert going from originally from like 1,600, first of all, down to 1,000. So I don't think we know.
Do you think it's possible that we quit the testosterone too early? The protocol called for 328-day cycles.
I don't know.
I don't think so. This is Bill Burhans. It is counterintuitive to treat a patient with high levels of testosterone when that's supposed to be what's fueling the cancer cells. And whatever the protocol is, I think they probably need to follow it very carefully because there is the danger that they could start feeding the tumor if they don't do it exactly the way that has been worked out. So I doubt that they stopped it too early. I think, Rick, probably the mechanism has something to do with when you flood androgen receptors, they are downregulated. And so you end up with far fewer receptors on the surface of the cell because the testosterone signals their downregulation in their expression. And then that combines with the use of, with other drugs can exert the anti-cancer effects. Does that make sense?
So what exactly does downregulated mean?
It just means that their expression is reduced.
Mm-hmm.
So there are far fewer receptors.
Okay.
They're also, internalized once they bind to testosterone. Then provides a signal for them to go into the nucleus where they, do their thing.
Mm-hmm.
So in the end, there are far fewer receptors on the surface of the cells that are available to interact with testosterone.
Mm-hmm. Well, again, this is all good stuff. We're all learning a lot. I mean, as far as the practical application, I would say Frank and Albert, for both of you really need to get your tumors sequenced. And Frank, as far as you're concerned, the question I would want to be asking your new doc is, can you please provide me any evidence that nivolumab or Opdivo is appropriate for my disease? You know, why Opdivo rather than Keytruda? And if he says, well, you know, if you prefer Keytruda, we can go with Keytruda, the answer is, it's not what I prefer, it's what my mutations indicate. We need to find out what my mutations are. Because they shouldn't be throwing these drugs at you with no good reason, in my opinion.
And Albert, in your case, I think it's pretty clear to me that you're accumulating lots of mutations in DNA repair genes. I mean, this is what happens, you know, to most prostate tumors, but it may be especially the case for you. And that would make you a good candidate for taking the drug that I'm taking, olaparib. But it would be helpful to know, you know, whether or not you actually do have mutations in some of these DNA repair pathways. And that.
How do you spell olaparib? How do you spell that?
Okay, it's spelled O-L-A-P-A-R-I-B. Did I get that right?
Yes, you did.
A-L-A-P-A-R.
I'll put it in the chat box and we'll spell it again from
O-L-A-P-A-R-I-B.
Right. I just put it in the chat window. But, you know, having said this, yeah, you could
You
be.
need an O after the P. Or an A.
O-L-A. Oh, I misspelled it. Sorry. Let me put it in again. Let me put it in again. O-L-A-P-A-R-I-B.
Yeah.
Olaparib. There we go.
Yeah, there you go.
Okay.
Yep.
So.
Where do you see it in the chat window? All the way at the bottom?
Yes.
The chat window is.
Oh, I see it. Jeez, doggone it, Al. I think I'm going blind.
No, that too. Not that too, Al. But guys, you know, I just cannot impress upon both of you how important it is to get that tumor analyzed, genomically analyzed. I mean, yes, olaparib may be right, but it may not be right. But Keytruda might be right. Nivolumab might be right, and there are other drugs. Lynparza is olaparib, but you know, there are about 5 or 6, 7 of these drugs that are being more and more widely used. They're expensive drugs, but they're effective. If you want to hear how effective they are, I'm going to just jump ahead and I'm going to let Bill tell you. How effective are they, Bill?
They're very effective. So you guys, I don't know if you remember, I need to tell you, first of all, that I have a germline, meaning inherited mutation in a DNA repair gene, specifically in the BRCA2 gene. So this is the one that was made famous earlier. You know, it's mostly been associated with ovarian cancer and breast cancer in women. And most oncologists who treat prostate cancer aren't even aware that it can cause prostate cancer. But I have a pathogenic mutation in the BRCA2 gene, and it is responsible for my prostate cancer. And I'm taking olaparib, which targets specifically that mutation, and as well as a few others in the same pathway. And so I've been taking olaparib now for about 1.5 years. And a 1.5 years ago, I don't want to get too maudlin about this, but you know, I had an oncologist, some of you have heard this before, I had an oncologist look me right in the eye while I was in the hospital and tell me that she did not expect me to be around the same time next year. And I'm still here a year and a half later. I had a lot of mets in my spine and in my ribs. And the bone scan that I had 2 weeks ago indicated that only 2 of those metastatic lesions continue to be detected. The rest are just simply gone. We've been watching them melt away over the last several months. And my PSA has dropped from, it never was extremely high, but it dropped from about 11 or 12 down to, it reached a nadir of about 0.3, I believe. But I never, I did not have a prostatectomy, so I still have some, prostate tissue, and which means that my PSA is never going to go down to 0. But after going down to that level, it's crept up a little bit. It's now about a 1/10 of a point above that, and in this last 3 months, it's gone up only by 2/100ths of a point. So it's remaining pretty stable, and so this is a extremely effective response to this drug. And
can I get you to spell that Alatride again, because my wife can't find it on the internet?
OLAPARIB.
Okay, starts with an O. Okay.
Yeah, but again, I don't want you starting to do big research into this, because we don't know if it's the right drug. The point here is there are a whole bunch of drugs, and there's no point in going in and saying to the doc, well, what about olaparib? Because that isn't, until we do the genomic analysis, we don't know which the right drug is for you. And if we don't know, we shouldn't just be throwing a drug at you. And that's one of the problems I have with him saying, okay, well, we're going to try nivolumab. These drugs have side effects, and some of them are significant side effects, and Frank is very sensitive to side effects. So don't just throw a drug at Frank just because he thinks it might be a good idea, which is all he can do because he doesn't know what the mutations are.
Yeah. Okay, so we go round in the circle back to the genetic testing. Okay.
Right.
It's like the PSA test. The testing is only about information. What it'll give you information to indicate the treatment, but to determine a treatment without having the information is inappropriate.
Yep.
Rick, who do you go to for the genomic analysis?
Well, first of all, they need to take a bone biopsy, which would be done at your local hospital. And then it gets sent to Foundation Med. Well, there are many options, but I personally, and I think Bill would agree because we've talked about it, I would probably send it to Foundation Medicine. They have a very good panel. By panel, I mean the genes that they compare to.
Okay.
It's something that you're, well, you have to get the cooperation of your oncologist. He has to do the biopsy.
Usually it's not he actually that does the biopsy. It's usually an interventional radiologist that will do the biopsy.
Oh, you're right. Yeah, I actually had one and I forgot about that. Yeah.
So, it's an interventional radiologist who will try and identify. I mean, ideally, if you've got a lesion in your hip, your shoulder, those are pretty accessible. They're easy to find. When the lesions are only in your spine, it makes it much trickier. If they're in your ribs, it's trickier because the ribs are so skinny.
Why don't the doctors do it? Come up with this themselves? I'm in South Carolina, and you know they didn't know anything about the bipolar treatment. So you know it's new to them.
Okay.
But you know, for the genomic testing, I talked to my ex doctor about it. He goes, I don't know how to do it. You know, and now I find out that there's ways to go about doing it. I don't know.
Okay, but an answer is I don't know how to do it. That's not an answer. I wouldn't accept that answer. I would say, can it be done? If it can, if you don't know how to do it, but it can be done, who can do it for me? And this is where you as patients have to be proactive. To me, that's an unacceptable answer. I don't know how to do it. So, you know, so to answer your question, number one, this is one of the reasons why we repeatedly recommend you have a genitourinary medical oncologist on your team. He may not be the person you see all the time, but if a guy or a woman is a GU med-onc and specialized, they know what's going on in this field. Most community standard medical oncologists don't keep up with prostate cancer. They know one way to treat it, which is hormone therapy. And now they're learning more about chemotherapy because they only thought chemotherapy was useful as a palliative and not as a curative treatment late in the disease. And they are way behind. So one of the reasons we run these calls is to give you the information, to feed into the doctors, to make them go and do the research that Bill says he's going to be doing later because he wants to know, you know, well, how does a limpter come into this equation? I mean, I don't know how a limpter comes into the equation. I don't know why your doctor thought you might be responsive to a limpter, what he'd seen, but if he knows to be using drugs that are somewhat off-label for prostate cancer, he should know about testing for gene mutations. But again, I feel strongly that anybody with advanced cancer should have a genitourinary medical oncologist somewhere on their team.
How do you find them, Rick?
Well, we talk about that all the time here, Albert. I mean, they are mostly they're at the strong research hospitals. So for you, as we've said before, you could find one at MD Anderson. You could find one at Duke. Those are two centers that are relatively close to you. Emory maybe, but I mean there are a couple at Emory, but they're probably more of a second level. Probably nowhere. Oh, in Florida, there are at Moffitt. And you know,
what do you call these guys?
Genitourinary medical oncologists. Urinary. And I'll put it in the chat box for you.
Okay, thank you.
You know, we talk about this all the time on this call. And the abbreviation is GU. So, you know, you want a GU med-onc, a GU medical oncologist. And again, I mean, people on the call will tell you that they found great benefit from seeing a doctor that has this specialty. So, you know, if you run over now and check yourself in, you know, go see Paul Korn at MD Anderson. You know, you don't need to see him all the time. Maybe a local guy is willing to work with him, and they work in unison together. But you know, he's going to know how to get you tested. And if your guy doesn't know how to get tested, he can call me. He can call Bill. You know, Bill's a cancer research professor with direct experience. So, you know, if he doesn't feel comfortable calling a layperson, let him call Bill. And we'll tell him how to get you tested. I can connect him. I can connect him to a patient support person at Foundation Medicine. We have one now on our advisory board. So, you know, there's a lot of ways to go if these guys don't know, but they have to be big enough to say, I don't know. This is what I'm going to learn from this, and I'm willing to do it and to work with you. Or you've got to go to a hospital where it is much more common to use genomic testing.
Rick, I have a question.
Please.
On the bone biopsy, why did you have to go to the hospital for that? Do they put you out? Do they put you under anesthesia for that, or is it a inpatient thing, or what?
No, I mean, I don't. They do put you under anesthesia. I think it's only a local though, and
okay.
I don't know.
It's a twilight anesthesia.
Twilight. Thanks, Frank. So, and I don't think you have to go to a hospital. Frank, you didn't. They did it at your
Yeah, I did. I went right to a special room with a CT scan and
right.
a radiologist or whatever he was that took the bone sample.
Right, but it
wasn't a hospital because they have to chisel into the bone to get it.
Right. So, Jake, it may not be, if they have the facility in the doctor's office, they can do it in the doctor's office, but they need equipment that oftentimes you might have to go. Like, I mean, if you wanted to get a CT scan, could you get one in your doctor's office?
You asking me?
I think for bone biopsies, Rick, they need really specialized equipment.
Okay.
That when I had one at Sloan Kettering, for example, there was a CT scanner positioned just above me on the operating table.
Okay.
And they were able to see in real time as they inserted the cannula or the needle. So I don't think that, this is really specialized equipment that you could only find at a major cancer center. But that's okay. You just go to the major cancer center. I mean,
it's not just a major cancer center because Frank was able to get one in northern Idaho.
We're tied to a fairly major cancer center.
Yeah, but what we're saying is they have the equipment.
Yeah, the hospital had the equipment.
That's right. I mean, we're not talking about it, although obviously they didn't do a very good job because they didn't get a sample from you. So, they may not have the experience.
They didn't even look at the sample before they sent it off, so that that was my oncologist bitch, was that they never looked at it to see whether they got the cancer and sent it off and it came up blank empty.
Yeah, this is crazy. I mean, all it takes is to spread a little on a microscope slide and make sure that they have tumor cells before they send it off. I mean, I think part of the other problem, even if they have the equipment in northern Idaho, they don't have the patient base.
That's right.
Where they're going to be doing this, routinely, day after day. And so, it's something that you need a lot of practice, I'm sure. I mean, it's very, very tricky. It's, they're working in an area where there are lots of nerves and where they could do a lot of damage. And so, it's not simple. And if they don't have patients coming in every day that need, that they can perform this technique on, then they're just not going to know how to do it correctly.
Absolutely.
Well, what's interesting is that they did the original biopsy to confirm that I had bone cancer, and that showed something up, but that was before Foundation 1 showed up. That was 3 years ago. So
Frank,
it isn't that hard to get it.
Frank, the other alternative for somebody like yourself, maybe even for Albert, is to do a prostate biopsy. Because one thing we do know, and again, your local guys may not be aware of this, but I mean, Frank, your guys should be aware of it because this research came out from Pete Nelson at University of Washington. But we know that unlike many other cancers, prostate cancer within the same man is very homogeneous throughout its tumors. In other words, doesn't matter where you take a sample from, it's going to have the same genomic features and composition. Now that's not true in other cancers, but it is true according to this work. If you're interested, I can send you the reference. But it is true, and this is what Pete Nelson published last summer. And so that means that if you've still got an intact prostate, that especially if it hasn't been radiated, it may well be possible to do a much less invasive procedure, which and take a sample of the cancer from your prostate and send that off for analysis.
It's also possible. Oh, I'm sorry. I just wanted to say it also might be possible to use the original cores that were taken at your first biopsy of your prostate tumor.
Yeah, but you know, I would be very reluctant to do that, Bill, because the cancer changes so much and so quickly that if it core's 3 years old, it's not going to be current enough. I mean, yes, absolute worst case, but I'd be looking for a much more recent biopsy sample.
I agree, but if nothing else is going to work, that always is a possibility.
Agreed. Guys, I'm going to move on because we've got other people on the call. First of all, let me do a quick roll call, and because we've got 3 or 4 new people, so I'll tell you who I know is on the call, and then the new people can give me their names if they wish.
Thank you, Rick. I appreciate it.
It's a pleasure, and you know, call me offline if you want more information. But please, please, please try and get this biopsy done.
And Frank, and if I can help in any way, Frank has Rick has my email address.
Yeah.
And he can give it to you, or you know, somehow we can, however you can contact me, I can help you too.
Okay. Thank you very much.
So Rick, I'm going to have to go here.
Okay.
And so I will catch up with you on
fine. Thanks a million, Bill, for all the information you've given us. I owe you an email response. I will be writing to you in the next 24 hours.
Sure. Okay. No rush.
Okay.
All right. Good night, everybody.
Good night. Thank you.
Good night.
Okay, so let me run down who I know is here. We've got Jake Hannum, Peter Kapka, Bill Franklin, Frank Kelly, Jim Cameron, maybe not. He may have left us already. Mel Smoke, Paul Frieda, Sylvester Mann, Albert Biasillo, Rich Catapano, Eric Bookbinder, and who else is with us now?
Len Sierra.
Hello, Len Sierra.
Hello, Rick Davis.
Anyone else?
Mike Tamales.
Hello, Mike Tamales.
Hello, Rick.
Anyone else? Okay. So, Len, do you have anything you wanted to talk about tonight?
I do not, sir. Thank you.
And Mike, do you have anything you'd like to talk to us about tonight?
Well, just that my PSA went up a little bit.
Okay, we'll come back and we'll check in with you.
Okay.
Okay. So let me just go down the list here. We got 45 minutes or so, 40 minutes. So hopefully we'll have time to get to everybody. So let me start with Bill Franklin. Bill, are you still with us? Oh, he must have stepped away.
Yeah.
Oh, you are? Great.
I'm here.
Excellent.
Yeah, I'm in my front yard looking for something my kids lost. So.
Okay. Go ahead.
Yeah. Yeah, so, I wish Bill would have stayed on because I would ask him about this, but I know you went through something similar.
Right.
I got my bone mineral density scan back, and it's not bad. It's osteopenia.
Right.
I did a spine, a neck, and a hip.
Mm-hmm.
And a 1.3, 1.4, and a 1.3 respectively.
Mm-hmm. Mm-hmm.
But the thing that, well, the radiation on not oncologist, but the radiologist, who happens to be a friend of ours, he said he thought that the progression was pretty rapid, because when I got it at the beginning of ADT, I had a like a 0.8, 0.9, 0.8 change.
Mm-hmm.
So he thought for 1 year that was a pretty drastic change.
Well, I can talk about the other way, and I can tell you, I can just to give you a frame of reference, and then we can talk about what to do. So when I got measured, I was minus 2.4, which is right on the button of osteoporosis as opposed to osteopenia. Let me just explain to the guys what these numbers are, because they're really weird numbers. There is a universal scale as to what bone density, average bone density should be. And I think it's something like a 30 or a 35-year-old male. And they do these scans, and then they plot them, and they find out how many standard deviations, I think it is, you are from the mean, and that's the number that you see. So minus 2.5 means you're on some weird scale, you're minus 2.5 away from the mean. But the problem is that as we get older, our bone density thins anyway, so none of us, or few of us, are going to be comparable to the mean number, because the mean number is for a 35-year-old. So if you're negative, like minus 2.5, it means that your bones are thin enough that you probably need some sort of treatment. So Bill went from being minus 0.8, which is well within the norm, to minus 1.3, 1.4, which is what's called osteopenia, which may need some treatment. But the concern is how quickly he got there, because bone density doesn't change a whole heck of a lot. But when you're on hormone therapy, especially if you're on for a longer period of time, it's a really good idea to get a bone scan once a year. You don't need it if you're healthy, but if you're on hormone therapy, it is a good idea for the very reason that Bill's raising. Now, because I was so close to being osteoporotic and relatively young and otherwise in good health, and because they expected me to stay on ADT for about 2.5 years, they decided to give me a bisphosphonate drug, in my case Zometa, but they only gave it to me once a year. Now, most of the guys who are getting Zometa, like Jake, get it, or I forget, Jake, are you getting it, Zometa or Xgeva now? I can't remember. Zometa, right?
Zometa, yes.
Yeah. So they get Zometa about every 6 weeks. But we've always thought that was probably a little too often because of the side effects. And now there's a new study that says 3 months is just as good as 6 weeks. But in my case, I got it once a year. My bone density improved over 3 years from minus 2.5. I'm trying to remember whether, I think it was they measure it in the hip and the spine and sometimes in the femur head. And I think my minus 2.5 was, I think it was my spine. I can't remember. But it went from minus 2.5 to about 1. In the first year, it went from minus 2.5 down to about 1.9, and then about 1.5, and then it went down to 1. And I did that with a combination of the drug and doing specific exercises that were bone strengthening exercises. This is why we always recommend weight resistance exercises, because weight resistance exercises improve bone density. So maybe some of this stuff that you've heard on these calls is starting to make more sense. So to circle back to Bill, I I think I would probably be, who's your treating doctor at this point in time? Who's administering the ADT, Bill?
Dr. Charles Brooks is my, he's the genitourinary oncologist. So he's in the same practice with my urologist.
Okay.
But I've been to his office to get the last few shots. But now he did bring me down. So initially he was one of those guys that said 36 months for ADT.
Mm-hmm.
And he has since changed it to 18 months.
Yeah.
Based on a lot of the reports that we've read, that we've discussed in this group.
Yeah.
So the radiologist, who, like I said, happens to be a friend of ours, he thought it was very rapid, but Dr. Brooks said you're gonna get your last ADT treatment in June, so you're probably gonna improve after that. So he didn't want to give me anything, and he didn't say Zometa. He said something that was similar to Zometa called Reclast, or
Exgiva. And there's a milder form of Exgiva called Reclast. Well, not milder. There's Prolia, there's Reclast, and there's Exgiva. I think they're all the same. It's just the amount that's in the. It's just the amount that's in the drug. See, the thing is, what you don't want to be doing is taking Fosamax, because that's a really awkward drug to take. You have to get up early to take it. You have to be upright. It's got to be before meals. So you want to try and everything. You want to try and stay away from Fosamax. If he's willing to give you one shot, I mean, if it were me, just based on my experience, I'd say, look, just give me a shot of something, just so that it helps me over the next 6 months, and then try and concentrate on your weight resistance exercises. I mean, for example, I was doing specific stuff for my spine, which I was able to do. So I was doing squats, with some weight on my shoulders and stuff like that, because it's kind of hard to figure out exercises that are weight resistant for your spine. But talk to some trainers and try and get a good exercise regime together. And again, as I say, if it were me, I probably would ask for a shot of something.
I mean, that was one of the things that surprised me, was that I've been lifting weights through the whole thing.
Yeah.
Weightlifting. I did the 5K. Which I think I got. What's that? My mind went blank. When your arches hurt all the time.
Plantar fascia.
Yeah, plantar fasciitis. I think I got it in both feet. I don't know what's going on.
You were supposed to send me a picture, Bill, that we could post of you and from the race.
I got that. I do have to send that to
you. Do. All right. Well, look, let's move on, because I want to get to everybody. But I think that, I'm sorry, let me open it up. Anybody else want to say anything about bone density?
All right, fair enough.
Okay. But do talk to him about getting something, and we can talk a little bit about. I mean, I know a little bit about these weight resistance exercises that are good, but my guess is if you get something and you're only through now for another 6 months, or less, that you won't get much worse. I mean, I'm a sort of, one of my measures is right around where you are right now, and the other one is down to normal. So, okay, moving right along. Rich Catapano. Hello.
How are you?
Good. How are you?
I'm much better.
Well, I'm glad to hear that. Yeah, you didn't sound like a happy camper when we were corresponding last week.
Oh no.
Fill the guys in.
Well, I had blood in my urine for a little while,
went to get it checked out, and they told me it was due to the radiation I got 6 years ago or so, which I never heard of until that day. And then I spoke with you, and then I heard a couple of guys saying that they were starting to get that kind of problem. I went and got a cystoscopy, and but I had a lot of trouble with the bleeding, and I had the constant tubes put in because I would get a lot of clots, bleeding. So I went on twice. I had to replace the tubes. Yeah, catheterized. Sorry.
Right.
Then I went to another doctor, Dr. Benson, a urologist, and out of Columbia, and he told me to. He prescribed this medication for me, which is Elmeron. I don't know if you ever heard of that.
Mm-hmm.
He said it will. He tried to explain what's going on in my. He said that the capillaries, they're kind of like, they get like what they call corkscrews, and he said some of them come loose sometimes, and this stuff kind of puts the coating back on the inside of your bladder to help protect it and to keep them. He said it's not a cure, but it's supposed to help it. Except for the one fact is that it's like $700 a month. So that was a little damper on that. So I got a week's worth, and that was it. But I stopped bleeding all of a sudden, and I'm just waiting now. And they say it could come back, and then we'd have to go back in again and, cauterize more and things like that. So, you're left up in the air because there's really no real answer to anything.
So you're not bleeding now, and you're not catheterized. Is that right?
Right.
Okay.
That's been about a week.
And any pain?
No pain, no.
Okay. That's obviously a good result. Anybody else experienced radiation cystitis on the call?
See?
Hmm.
They said it's quite familiar. As soon as I told the doctors, they knew right away. They said, "Oh."
Yeah, well, I have, so I guess I can. I started spotting a little bit after about 2-3 years, and I went back and forth with my urologist, and because he said he wanted to do a cystoscopy, and I said, well, do you have to? And in the end, he said, well, if it happens, after about the third time, he said, if it happens again, we're going to do it. So I said, okay, and it did happen again, and of course, they didn't find anything other than some inflammation. And I think it does happen, and I think it is relatively common, even though we don't have anyone else right now on the call that's had it. And I think Professor Bill has been through this. Let's just hope. The one thing which is not really a medical answer, Rich, that I would like to just suggest or encourage, and it's easier said than done, is don't try and take these things as best as you can in your stride and live in the moment. Because when you start worrying about them, that's the worst thing that you can do, because it just stresses you, it stresses your immune system and everything else. And if it does come back, and given that you got a diagnosis of radiation cystitis, even though this was a nasty case, just know that it's relatively common and it can be treated.
Yeah, I guess it seems that's it. You don't have much of a choice. If it comes,
Right.
it comes. And, there's no way to prevent it from coming, and I just and I found it odd that I went to the VA to try and get the medicine, medication, and they don't have it. They said it's not on their formulary.
Yeah. Wow. Yeah, because if it was, I mean, is there, the only other thing I might suggest is to write to Benson, email him and say, and is there anything else that would be similar to it, maybe not quite as good, because I'd like to try and get it through the VA.
Yeah, I could do that.
I mean, we have a lot of prostate cancer drugs where the best drug available is expensive, but there are other drugs that do somewhat of the same thing.
Yeah.
And there may be.
Well, I know. It doesn't seem like there's much to it. You either get it or you don't, and if you do, you just hope you don't get clots. The clots are the problem.
That's right. Absolutely. And I personally was very lucky because I didn't have bad bleeding. It was hardly noticeable. It was really minor stuff. And I've had blood in my urine so many times from so many different things. It never bothers me.
Oh, that's good.
So
yeah, and like I said before anything, when I was bleeding for a while, it was just okay. I didn't have any other problem except that I saw blood and I had no idea what it was.
Right, and it's scary.
It was after what he did is when I started getting all these clots, and so I thought maybe they messed up something. I couldn't understand why I was getting so many clots, and who wants to go through those other things? But I like I said, I'm doing okay now. So in comparison to the other guys and the trouble they have, I feel lucky.
Okay. Well, stick with us. Talk to us some more next week. Keep us posted, and we'll move on. Eric, where did you say you were? Somewhere very nice. Where are you?
Can you hear me?
We can.
Oh, good. I'm in Puerto Vallarta.
Oh, excuse me.
Wow.
Villa del Mar.
I see. Okay. And how is Puerto Vallarta right now?
I'm sorry, what?
How is it? What's the temperature?
It's not as warm as I would like it. It's about 70 and it's about to rain.
Oh, okay.
And windy.
And windy.
But we're having a good time.
Okay.
Eating too much food, the usual.
Oh,
okay. 70 degrees.
What I wanted to talk about was, Rick, as you know, I'm getting treated in two places. So I'm getting treated in Berkeley and at UCSF.
Right.
And they each do their own tests. So we get interesting results by having two different systems doing the tests. So I had really good news that my PSA went way down at UCSF. Well, guess what happened at Herrick?
It went up.
10.7. Oh. It's by far and away the highest it's ever been by 25%. So I just got that result yesterday, so it's distressing, of course.
So just recap. So Sutter came back at 10.7.
Yes.
And UCSF was what?
I think it was 6.4.
Okay, I have a 6.022 from the 3rd of January here.
Yeah, that's it. Yeah.
And you haven't gotten tested again at UCSF, huh?
No, on Monday.
You see, the thing that I find strange is that your PSA doesn't move that much. And
not usually.
Not usually. And so, why would it jump? I mean, bone pain? I mean, you have been complaining of bone pain. Have you had a lot more bone pain recently?
No, I haven't had much at all. I've been taking the Norco every morning. When I started having the bone pain, I started taking a 10 milligram Norco every morning.
Right.
And
right.
That seems to have eliminated the bone pain. So I don't know. I'm also having, on Tuesday I get a bone scan and a CT scan.
Okay. Well, you know, my money is usually on UCSF only because they do so much prostate cancer there and their systems are generally pretty good. I just think that, you know, before getting too concerned, we just got to see what it comes out, and then you got to talk to. Are you still seeing Amy Lynn?
I haven't seen her in a year.
So who is?
No, I just see the people connected with the study.
Oh, okay.
And the
Agarwal.
The one PA that I was seeing every time retired, so now I have a new one who doesn't really know what she's doing. That's not fun. But I'm also supposed to see, what's his name, the head of the study. I'm supposed to see him. Yeah, Agarwal. I'm supposed to see him on Monday.
Okay. So, you know, talk to Agarwal's good. Talk to him about it. And
well.
And but I mean, I'm sorry that I'm sorry that you're in this position where you have this dilemma. At the same time, I just feel before you get too concerned about it that you know, we see what comes back. And the other thing is, I mean, I think, didn't you do a genomic test a long time ago?
Yes, I did. I was just looking at it. My wife asked me about it, and I brought it up. I was looking at it. Yeah, it has been quite a while.
How long ago was it?
Let me look at the date on it. Shoot, it doesn't say there. Let's try there. April of 2000. So it's not a year yet.
It's not a year. And there was nothing, and it was a bone sample or it was a blood biopsy?
It was done from the original tumor.
Oh, that's right. That's right. That's right. That's right. You got to get something from recent, Eric.
Yeah. Well, yeah. So I talked to Dr. Agarwal, and he said that they would be willing to do it. So I guess I'll push the issue on Monday and see if I can get him to actually do it.
Right. So let me give you one heads up on that. And I think it doesn't really matter for you, thank God. But if they do it, and they really do have the expertise. We were talking before about expertise. They have great expertise in doing these bone samples. They will, by default, send it internally. And their panel is very good. Not only is it good, but it tests DNA and RNA. The problem is it can take 4 to 6 weeks to turn it around. I think that the analysis is actually done at Oregon Health and Sciences University, OHSU. But it takes them a while. If you're pretty sick, it's not a good idea to send it down there. If you're feeling pretty good, you know, whether you get it back in 2 weeks or 4 to 6 weeks doesn't really matter. But if you're in a hurry, you should be sending it down to Foundation Medicine, whose panel is only DNA, but their DNA panel is almost as good, if not as good as UCSF. And they turn it around in 2 weeks. So I'm just providing you that with the information. You can go from there.
Okay.
I see.
All right. Well, that was.
Go ahead. No, you go ahead.
I just was going to say that was all I had. You know, just a big question mark.
I do enjoy Frida Kahlo looking at me right the way through this.
Frida.
Hey, Frida.
I guess it is Frida.
It definitely is.
Yeah.
Yeah. For those of you who wonder what the heck I'm talking about, Eric is sitting in a room with a white wall and a painting on the wall behind him, which looks very much like Frida Kahlo. So.
Yes. Yeah.
All right. Well, look. Will you please keep us posted? Please push for a recent a recent biopsy. I mean, you heard what happened with Bill, and there are other people it's happening to.
Yeah.
You know,
By the way,
yeah.
I hope to see you Sunday night.
Yeah. Would you just give me a buzz when you get back? When are you back?
Saturday.
Oh, not till next Saturday. Okay. So I'll confirm with you by.
Oh, wait, I'm sorry. It's not this Sunday. It's the following Sunday.
That's
is that
right. The 29th, I think. No.
That is this Sunday.
Yeah, it is this Sunday. It's the end of this month.
Okay. Yeah. So it's just in 4 days or whatever. Yeah.
Okay.
Okay.
So I'll send you a note, and you know, no, we don't have anybody else that's in the Bay Area on the call, but we're going to meet with Jim Cameron on Sunday and have lunch and have dinner with him. That's fantastic. I look forward to seeing you. Excellent. Okay. And Mike Tamales, tell us how you are.
Well, I don't know really where to begin. I came out more confused with my last doctor's office than I did when I went in there.
Mike, we can barely hear you. Can you start?
Yeah, okay. Is that
That's
better?
much better. Much better. Start again.
And anyway, again, I got kind of rushed at the doctor. I'm on my last round of Zofigo. I take that next month. My PSA went from 71 to 75 now. He says that the Zytiga that I'm taking is starting to affect the bone marrow, and that might have to go in for some vitamin shots. And he's got me set up to go do the Provenge thing in Honolulu, and that's about all I know at this point.
Okay. Well, did you say that he thinks that the Zytiga is affecting the bone marrow? Or the Zofigo?
I thought he said it was the Zytiga. Oh, brother. Well, whichever one, it's starting to affect the bone marrow, and he was saying that it might have to start going in for shots and stuff. And
speak up, Mike. Speak up.
Oh, okay.
That's it. You got to speak into the microphone.
Yeah. So right now he's saying just status quo and
right.
Get me to do the Provenge and see what happens after my last shot of Zofigo. I don't know what goes on from there.
Well, you know, the Zofigo takes time to work. So, you know, the good news is that your PSA is, you know, still in the same range. You know, whether it's 69, 81, or 77, 71, that's all pretty much around the same place, which means you're holding. And so,
yeah.
You know, that's positive, but it's not coming down. And the Provenge isn't going to bring it down, but the Provenge is going to be helping you. And you're taking Zytiga and prednisone, right? Or am I, or not?
Yes, correct.
Zytiga and prednisone, right? So, you know, it's interesting because the Zytiga and prednisone is also helping you hold where you are. How long have you been taking the Zytiga?
Holy moly, I don't know how many bottles I went through already. This might be my 5th bottle, I think.
You know, if you're getting, let me see, I think you started, I'm looking at my notes here, sometime maybe around May, or I think sometime around May. So, you know, you're getting a good run out of it because your PSA isn't going up, and that's positive. And it also means that Xtandi might be an option. But again, you know, the other thing which we've discussed, and Peter and you and I have all discussed, is the same advice. We need a bone biopsy. I know they sent off a liquid biopsy, but we didn't get much out of that. But you need them to do a bone biopsy. Peter, come in here.
Okay, I was with Mike last week at the doctor's office. Yeah, we were rushed through there. He was busy. He was a busy guy, and what to do? His biggest concern with Mike was his low white blood cell count, and he feels that Mike's very open to infection because it dropped significantly. So we're going back. Actually, Mike's doing another blood test this coming Friday. And we're going back next week to see the doc and see if there's any change in the blood count. I didn't hear him try to attribute the low blood count to anything specifically. He was just a little bit alarmed at the drop. I think it went down to 2.8 or something like that. I don't have Mike's numbers in front of me. He has them. So. That was the big concern. Now the other thing is, you know, to do Provenge, we've got to go to over to Honolulu to do that, and we're kind of exploring whether I should go over with Mike or whether his wife should go over, because you know I don't think, you know, I asked the doctor this, you know, whether Mike can actually do this on his own or whether he needs support, and the feeling is that Mike needs support for this. So we're going to figure out some way to go over there for the initial meeting, and then maybe the additional ones. So we're looking at that. We did make a call to the metastatic support organization that provides funding for travel and so forth, but they're out of funds. They have nothing to offer in that.
Mm.
But we'll look at other options and see what we can find.
Yeah.
Did the doctor talk to you about giving Mike a Neulasta shot?
No, he didn't, but I will research it, and we will be ready to ask him about that next week.
So, Mike, Neulasta is a drug they give you. It's just a shot. It doesn't have too much side effect, although I think some people say they feel a bit fluey from it. So if that's the case, then I think it's one of those drugs that it's good to take, what do they call it, the stuff you take for allergies. The over-the-counter medicine you take for allergies.
Oh, yeah.
Sorry?
Claritin?
Claritin, thank you. Claritin, yeah. So, you know, sometimes I think people sometimes they'll take a cup of Claritin with it, but it's just a shot and it boosts your white blood count. And there are a lot of guys on this call who have gotten it. They often give it to you later on in chemo. I don't know, anybody on the call gotten Neulasta?
Yeah, I have, Rick.
Okay.
I have also.
Oh, okay.
The only thing, insurance, my insurance won't pay unless the blood counts are a little bit low.
Okay.
And I forget what that magic number is, but I've had it probably a couple times.
And any response to it?
Maybe a little. You know, the blood counts do go up, the red and white.
Yeah.
You know, it's hard to tell. You know, without okay, this time let me do without, this time let me do with, you can't really tell what it is. But anyways, my blood counts now are good.
Good, okay.
And I did have Elasta shot. Now, the only thing with Elasta, I'm 1 out of 10,000 that it makes them very sensitive to light, to the sunlight. So I go out, I got to wear sunglasses and things like that.
Right.
But that only lasts a while.
Right. And so,
it does seem to help.
Somebody else, who was the other, who else was it that said they'd gotten a new Elasta shot?
I did.
Oh, hi, Mel. Tell us about it. Mel, tell us about it.
Oh, I didn't notice anything one way or the other. I got the shot and that was it.
Okay. 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 So I guess that's the thing to discuss. And then one other question, and then we'll wrap up, which is, weren't we going to try and pursue a bone biopsy for Mike? I know we got a blood, but what happened with the bone biopsy?
We didn't really get any place with it. This doctor we have is very hard to pin down. We will pursue it again. We'll look at it again for sure. But it's rush, rush, rush. He kind of runs into the room and runs out of the room. And if I wasn't there, I mean, Mike would just about see his shadow. I mean, I'm able to pin him down for one question, maybe a month. But we will discuss it for sure.
This has to be sooner rather than later, Mike, and
yes,
because my guess is that Mike's cancer is changing, and we need to try and find the right drug for him. And it's no good going in once a month and he doesn't have the time. Basically you have to go and stand at the counter and say, I need to see this doctor and I need 15 minutes with him and we need to talk. This is my life.
Right. Last night we had a meeting with some others who were frustrated with this oncologist and told us about another one on the island. And we might try to make an appointment for another consultation with the other guy. We just want to do some research and see if he's up to speed with prostate cancer.
I mean, this guy seems to be, he's never been that cooperative. And if there is money on the island to get a bone biopsy done, as was indicated, we need this bone biopsy. I mean, there's no question about it. With this bone biopsy thing today, I sound like a broken record, but you guys heard the response that Bill Burhan's got, and I know somebody else, albeit with ovarian, who also got a phenomenal response from a drug. I know somebody with lung who really held their own for way longer than they should have done because they're taking a drug. So we need to know whether you're going to respond to these drugs. Then we've got to figure out how you're going to get them, but we need to know. And, we've been talking about this biopsy for too long, and somebody needs to shake this guy's tree. And if we can't do it, then talk to us and we'll figure out a way to do it. We'll try and get some people, like maybe Bill will have to put a call in or somebody. But we got to shake this guy's tree. We'll talk to prostate cancer. We'll talk to our friends at, Turner and Schultz and say, what do we do? How do we move this guy off the dime? But it has to be done before it's too late. I don't mean to. I don't want to alarm you. I'm not going to sit here and see the same thing happened as happened to Trevor last year. Because it
agreed. Right.
Okay. Enough. Sorry. I'm not beating up on you, Peter, because what you're doing is amazing, but it's just frustrating for me to hear that we can't even get the doctor to focus enough on somebody where we think there's something that could be done. All right, guys, it's 5:03, the witching hour.
Guys, I just wanted to check in. This is Steve Korn. Wanted to say hello. I dialed in later.
Oh, hello, Steve Korn.
How are you?
Good.
I got the time wrong. I was expecting a different hour, and that's the only reason. But I'm still glad I dialed in. Thanks.
Okay. Well, Steve, listen to this one. I'll post it. It'll be up there tonight. There was some really good information in the first hour that I think you'll find very helpful and useful.
Okay, thank you. Hope everybody's doing well.
Thank you. We may have a plan. Next week is the 5th Monday of the month. We may have a plenary session. I would say there's maybe a 20% chance that it will happen. I'm working on it. But if I don't find a speaker, then we won't notice a call, or if we notice, it'll be that there is no call. But for sure the next date after that is, I guess it's going to be the 7th of February. I think that's a Monday, isn't it? Let's just see. No, the 5th.
6.
Oh, the 6th. Sorry, the 6th. The 6th of February. So we'll talk again on the 6th of Feb if we don't speak next week, and I don't. And just a plug for John Teisberg's Inner Conversation. That's happening on Thursday. But it isn't John Teisberg anymore. Jake, give yourself a plug, man.
It's going to be co-moderated by me with John's backing. I think he's. I don't know why he's backing out of this. I haven't really been able to find out from him, but it's two of us, Rico Boyd and me, will be co-moderating it off and on, and we welcome everybody to join. We don't have the technical expertise that Rick does. Those kind of questions won't be answered. But it's more of a discussion about emotional aspects and feelings, kind of a touchy-feely thing, which is something that's very difficult for most men to share. And it's not always easy. It's easy to talk technical stuff. It's easy to, say, well, I had this, and this, but trying to express to other men how you feel about something is sometimes hard, and that's what this call is all about. So please join us, 8 o'clock on Thursday.
Great.
8 o'clock Eastern, that is, and there's a lot of good support that comes out of that. There's a lot of laughs. There's some funny guys on there, and if you haven't tried it, you can come in with GoToMeeting. You don't want to identify yourself, you don't have to. You can call in on the phone, same thing. But try it. It's they're good meetings, and they get it. There are no women on the call, so the calls can get a little bit bawdy, wouldn't you say? Is Frank still with us? Frank will attest to that. No,
Frank usually has some stories to tell, yes.
Yeah, he's left us, but Frank has some stories, and so that's a good call. It's coming up this Thursday. All right, guys, great call, really good call tonight, and I'm looking forward to posting it so other people can share in it. I'll say good night to everybody.
Thank you, Rick.
Thank you.
Thank you, everyone. Right, goodbye.
Bye, everybody.
Thank you, Rick.